I would like to welcome everyone to this meeting. This meeting is in the 26th anniversary of the meeting. For the last 2 years, we've been extending the opportunity to the surgeons especially, in the sense that we are trying to make it a Heart Team Summit, and therefore not only to the surgeons, but also to all of the other colleagues involved in patient care. That is the nursing staff, technicians, that is the anesthesiologists, the echocardiographers, the imagers. So what we mean to do is to put patient at the center of the discussions. And the very important second word is discussion, because we do not mean this meeting to be a strictly formal meeting where people give talks and other people listen to talks. We want this meeting to be very interactive. We will put microphones. I will be trying to get people from the audience to speak up during the meeting, to discuss, give their opinions. Everybody here are experts. We are all in the same field, and we cherish the people that actually take the opportunity to tell what they think about this, about the given case. And therefore, we've carefully selected the cases to make this interaction as positive as possible. When we will do live cases during this meeting, we strictly obey the rules of engagement that were set up by the major scientific organizations. And therefore, when we do these live cases, we need to be extremely respectful of the patient first. And when we do these cases, we select the cases for their educational values, and we carefully select cases only if there are additional teaching objectives that cannot be achieved otherwise. So suffice it to say that when we do these things, the patients are totally aware that they are being filmed and so on. So when we do the comments, because sometimes patients can actually hear the comments, we'd like to be extremely careful with how we say it and how we do things. In addition, we try to make it extremely academic. So whenever we have given material or whatnot, this is strictly because we think the patient deserves a given device and so on. So there's nothing to do with the program or the sponsors. And I would like to thank the sponsors, because without the sponsors, all of these meetings could not be done. Although they sponsor the meeting for sure, this meeting is strictly organized by the scientific committee. The scientific committee has gathered 7 times to discuss the program, to discuss live cases, to prepare this. So we want this to be a really good meeting, a meeting that you will want to come back to, and a meeting that you will put on to tell your colleagues that they should come to. So without further delay, I would like to ask the first speaker, which I think is Bob, to discuss the approach to left main, because we have selected left main intervention as one of the main topics of this meeting, because there were lots of new information in the literature, and we want to present the literature, present the available data, and then we will discuss cases. And this is how we want this meeting to happen globally. So thank you so much, and have a good meeting.
Ladies and gentlemen, colleagues, and distinguished guests, it's an honor for me to be here. This is my second year attending this meeting. It's a pleasure to have a forum where we can have a heart team approach of dealing with different cardiac disorders. I would like to thank Dr. Lallier for, again, the invitation, and Dr. Jean-Mar. It's a pleasure to be here. I'm looking forward again for 2 days of great discussions. Can I have my slides, please? Thank you. So I was given the task of giving an update on left main revascularization in terms of surgeon's perspective due to the most recent, you can say, publication that recently has occurred in terms of left main. How could I go to my next slide? Yeah, it doesn't go. Oh, okay. These are my disclosures. There's a bit of a delay. I guess I got to be a bit patient. These are my disclosures for this particular talk. So learning objectives specifically is I'm going to talk about a team-based approach to left main disease, evidence-based recommendation for left main disease, and of course, I'm a big proponent of hybrid approaches to different coronary disease and how a hybrid approach would be beneficial for this particular disorder. So what's left main? Well, the definition is disease of greater than 50% based on the angiographic finding of the main trunk of the coronary artery. It's about 4 to 6% of all patients undergoing coronary angiography are found to have left main disease. Most of the time it's associated with multivessel coronary artery disease 70% of the time. And intervention generally is recommended to be performed urgently to avoid the complications. And of course, in the past, CABG has been the preferred choice, but most recently, again, I will show that actually we have to be open-minded and basically provide the best care for the patient. So these are different ways by which left main can show itself. You can have ostial left main, you can have mid-body, you can have right at the bifurcation, and all these require different treatments. Dr. McGilvery, in the New England Journal of Medicine in 2004, stated the management of ischemic heart disease has evolved dramatically over the past 2 decades. The surgical treatment option must be tailored to each patient in order to optimize the benefits and minimize the risk of detrimental effects. And this is where heart team approach comes in. We have to use expertise of the 2 different, you can say, disciplines that provide care for patients with cardiovascular disorders to tailor the care to the patient. So I think, first of all, we need to go back and understand how can we properly assess in terms of what we are treating. So therefore, in order to be able to provide an intelligent revascularization. So angiography may not be the definitive finding because you can have diffuse disease and you can be obscured by bifurcation. So therefore, this is when the physiological invasive assessment, I think, is extremely critical to properly assess the extent of left main disease you have. In the FAME study, interestingly, as you can see, you've got different angiographic narrowings here. You've got one that doesn't show significant narrowing, but the ones that are greater than 70% and ones that's quite severe. Interestingly, of course, if you look at their FFRs, the patients that had not significant angiographic disease of left main, 35% of them still had positive FFRs. So I think we need to properly assess these patients before we tailor the type of treatment. So these are the group of people that basically is questionable. And if you look at, again, FFR, this study has shown that if the FFR is significant, definitely we do better in terms of prevention of MACE in a 1-year period if the FFR, of course, is less than 0.75. However, if they get medical treated, they do worse. And if we do actually invasive intervention of them with a FFR that's greater than 0.8, they do worse compared to the medical treatment arm. And you can see the 2-year free of death and MI, the FFR guided, they do much better compared to just angiographic guided therapy. Another assessment is image guidance. I think IRIS is extremely critical for assessing left main, for making sure that we have proper luminal, basically abnormality before we go ahead and any type of treatment that is basically advised for the patient. And if you look at this in terms of the lesion length, I think with IRIS you can see you can have significantly much more better understanding how much is the length of the disease that you have involving the left main compared to just angiographic findings. So, as I said, you have ostial, midshaft, or bifurcating type of left main disease. And if you look at what's the frequency of involvement of the LAD and the circumflex, up to 62% you involve both in bifurcating disease of both the left anterior descending and the left circumflex. And this varies along 14% to as low as 1% where only the left circumflex is involved. This is an example of a bifurcating lesion. So the Excel trial, which was probably a landmark paper after the syntax, allowed us to understand better how to basically deal with left main, was basically a prospective randomized trial comparing drug-eluting stents with bypass grafting in selected patients with left main disease. Interestingly is most of these patients were treated with CABG in the past. Now, since syntax, again, this myth about how to deal with, I think, left main disease has changed. And now I think that PCI is definitely an acceptable treatment for these patients. And I think that we should definitely work as a team to provide the best care. So in Excel trial, the people that were in the inclusion criteria were people who had definitely evidence of left main disease greater than 70%. And of course, if they didn't, non-invasive measurement, as I just mentioned, with IVUS or with FFR has to be either less than 6 millimeters square diameter or FFR less than 0.8. Syntax score had to be less than 32. So if you looked at the findings of it, I mean, as you can see, this showed that very similar finding. But I'll bring your attention to death from any cause. As you can see, the curve started to diverge at the 3-year period where, again, CABG showed some benefit. And I think this is something that we need to look into to see why and how we can improve that. And then also, if we look at the subgroups, specifically the elderly, the diabetics, and also people with the higher syntax scores, there was generally a favor towards CABG in these patients, which is expected because the younger you are, probably it's better for you to potentially have a CABG, and the older you are that you've got potential comorbidities, a PCI approach would be more beneficial. And if you look at, interestingly, with 77% of the patient had IVUS-guided therapy in Excel. And if you look at, again, the findings in terms of ischemic revascularization, graft occlusion, stent thrombosis, there's definitely, as you can see, advantage towards PCI when it comes to stent thrombosis versus graft occlusion or ischemic revascularization. The graft occlusion, I think, primarily, again, is a selection of basically what type of therapy you provided for the patient. You looked at these meta-analyses of different studies. Again, it's shown again that they're very similar PCI to CABG for treatment of left main disease, specifically looking at death, myocardial infarction, and stroke. And then again, looking at the same type of, again, meta-analysis at the different studies, dividing all these into the death, stroke, repeat revascularization, myocardial infarction, there's definitely advantage to CABG towards repeat revascularization, but with the other entities, it's very similar. So I think all the studies have shown that IVUS-guided therapy is beneficial, specifically when you look at such basically entities as mortality, MI, target revascularization, also stent thrombosis. And again, you can see here with IVUS-guided therapy versus angiography, stent thrombosis and mortality was higher when it was angiography-driven versus IVUS-driven. And then also for target lesion revascularization, when it's IVUS-driven, again, better results. And I think this is the curve that I mentioned to you as it diverged. I think if you look at that, one of the reasons behind it probably is if you look at dual antiplatelet therapy, at 3-year period, we had decreased amount of people that were on dual antiplatelet therapy in the PCI group. And I think maybe this could have been prevented if the dual antiplatelet therapy could have been basically potentially gone for a longer period. So in terms of the guidelines by the European Society, based on the syntax score, if the syntax is less than 22, PCI and CABG are both level 1 indication. If syntax is 2332, 2A for PCI, 1 for CABG, and of course, if the syntax is higher, CABG is the preferred mode. And I think that I'm just going to allude over the last few seconds in terms of heart team approach. I think that these patients have to have a heart team approach towards their treatment, a multidisciplinary type of approach where you provide the best guidance for them based on image guidance. I think that by adopting disruptive technology, we can basically modify the care that these patients receive to provide the best care. This is our surgical revascularization and kind of revascularization team. And of course, the ITA has been shown to be extremely effective in terms of longevity and also survival. So if you take the ITA survival and know that basically saphenous veins have not been doing good in the past and combine them together with basically a hybrid approach towards that, this is, for example, a case where this patient had a bifurcating lesion, but the patient very high risk to undergo conventional surgery and also potentially having a PCI approach. So we decided to go ahead and do a robotic-assisted LITA to LAD, and then subsequent to that, patient underwent rotoablation, and then PCI into the circumflex artery, and this is the final result, and patient ended up being able to go home 2 days after the operation. So I think that hybrid approach is another toolbox for the surgeon and the interventionalist to look at the way they manage, I think, left main disease. It's extremely critical. The take-home points, I think, is that left main prognostically is important. We have to use IVUS and FFR to guide us for the best treatment. Complex syntax score overall, patient characteristics should define the best form of revascularization. If anatomically suitable and not high risk for surgery, I think CABG may be the best option. However, PCI definitely is a very, very reasonable alternative and should definitely be considered, specifically combination with hybrid. I think that the heart team are the ones that are going to be able to work together and seize the challenges that's required to be able to provide the best care for the patient. And the patients of the future will demand a combined approach or potentially the best approach to provide that. And we have to basically provide that for them and, of course, do the procedure when it's indicated. The heart team must modify the operations toward better ones to obtain benefits of rapid recovery, pain reduction, improved cosmesis, and neuroprotection. Thank you very much.